Now back. Sorry, the last video got cut short. So let's get back to where we were. So I think we were at counter conditioning. Get this out of the way. And so let's write down what that is. We talked about it's like conditioning backwards, right? So counter conditioning is behavior therapies that use classical conditioning to evoke new responses to stimuli that are triggering unwanted behaviors. All right, so you kind of condition them the way I said, like the US, UR, CS, and CR, but now you want a new response. You want a new ending. And so you want to get rid of that old behavior and replace it with something new, basically. There's two main types of counter conditioning therapies, exposure therapy and aversive conditioning. Okay, so exposure therapy is just like it sounds, like you expose the person to it. This is really good with phobias and stuff because it's like you slowly expose them to where, hopefully they wouldn't be scared of it anymore. All right, so exposure therapy, let's write that down. So this is a behavior technique such as systematic desensitization. We're going to take notes on that in a minute. Systematic desensitization. Desensitization. I always have a hard time saying that word. And virtual reality exposure therapy. So those are two types of therapies that are exposure therapies that treat anxieties by exposing people in either imagination or real life. Exposure therapy and systematic desensitization, that'd be more real life. Virtual reality would be in their imagination kind of thing. So in imagination or actual situations to the things they fear and avoid. All right, so you just expose them to it. So this allows behaviors like being around something you're afraid of to be reinforced to reinduce anxiety. So if someone's like super afraid, like you saw in the video with the psychological disorders with the phobia, like I was super afraid of dogs. So it's like you show them a picture of a dog and then you have a dog in the same room and then they get closer and then they finally like touch the dog or whatever. But it has to be gradual. And that gradual is going to be the systematic desensitization that you're going to see as people basically face their fear head on and overcome their response. Don't act the way you want. Don't run away. Don't avoid it. Don't freak out. Don't do this. Like that's a true phobia. But instead, like, let's be calm. Let's be cool. Let's, that type of thing. So systematic desensitization is a type of exposure therapy. Let's write this one down. A systematic desensitization, a type of exposure therapy that associates a pleasant, relaxed state with gradually increasing anxiety triggering stimuli. So, like I said, it's commonly used to treat phobias and stuff. So here's a video kind of on it that you can see. But the thought is that you cannot be simultaneously anxious and relaxed at the same time. Like you're one or the other. You're either freaking out or you're relaxed. So they get you relaxed, and then they introduce this thing that would have freaked you out, but they keep keeping you relaxed, right? So the trick is that you have to proceed gradually. So you don't just like throw a bunch of snakes on someone scared of snakes. I mean, they have a true phobia, panic disorder. I mean, they could have like a panic attack, like a heart attack. The trick is to proceed gradually. First, they use progressive relaxation to train the person to relax one muscle group at a time until they're totally relaxed in their body. So it's not just like me or you laying and relaxed. It's like a real technique, like a real thing to it. And then they move into actual situations from easy to more anxiety filled build in order to conquer their anxiety. But sometimes these situations are too hard, expensive, whatever, to imitate in real life. Like a person with PTSD, maybe they can't go back to the battlefield where they got PTSD from, but you want to work them through it. So you use like virtual reality, and that's what is in this right here. So virtual reality exposure therapy. Let me see what this says. 20 minutes. I don't think I have 20 minutes. Hold on 2 seconds. Already had to stop the last video. No point in doing it twice. So let's just plug up the computer so we ain't gotta worry about anything. Don't you love how real life these videos are? You're welcome. All right, so virtual reality exposure therapy. So virtual reality exposure therapy. So this is an anxiety treatment that progressively exposes people to electronic simulations of their greatest fears. So it could be flying, spiders, public speaking. Like I said, this person with PTSD, like the battlefield. And so there's an article and a video on that. The other type of classical conditioning was aversive conditioning. So it was counter conditioning and aversive conditioning. And under counter conditioning was the systematic desensitization and the virtual reality therapy. Now let's look at aversive conditioning. We actually kind of talked about this in Unit 7 or Unit 4 when we did the unit on learning and talked about classical conditioning. So it might sound kind of familiar. So aversive conditioning, let's write this down. A type of counter conditioning. I just said all that wrong, didn't I? Erase everything I just said when I did my little parts. I was wrong. So you have classical conditioning. You have counter conditioning, which is like all of them. And then in counter conditioning, you have exposure or aversive. Exposure or aversive. And in exposure, that was the systematic desensitization. That was the virtual reality. Now we're looking at aversive. I just confused you, my bad. So a type of counter conditioning, you're not going to need to know like the hierarchy or the organization structure of this, so don't freak out if I just confuse you. Just know what the things are. That associates an unpleasant state, and like the example, if you want to write down the parentheses, you can, like such as nausea. It's pretty unpleasant when you're sick on your stomach. With an unwanted behavior. Such as drinking alcohol. So if you were really going to get a person like who had a really big drinking problem to like really stop drinking, they're probably not going to get nauseous from drinking. If they have a severe problem, they've been doing this for a lot, they've been doing like for a long time, they do this in large amounts, they're not going to get hungover or anything like that. So you have to add something to make them sick. So you put like a drug or something in there that like induces, I'm not bending over to pick it up, I got another one right here. That induces nausea so that they get sick and then they feel like, oh, this is terrible, I don't ever want to drink alcohol again. I think we talked about it, like they did this with like coyotes who were killing all these ranchers' sheep, and so they laced the sheep meat with stuff that made the coyotes sick, and the coyotes quit killing the sheep because they thought it made them sick. So it's just you have this unwanted behavior, so you need to stop the behavior. Well, how's the way to stop the behavior? Do something aversive. Like aversive means like, you know, bad or against. So let's do something unpleasant, like throwing up, you know, or something like that. But some critics wonder, like, but how long term is this? Like, the person knows if they go drink alcohol at a bar and the therapist isn't beside them to slip the little magic throw up thing in there, then they can drink alcohol if they want and they're not going to get sick. You know what I'm saying? Like, they know that it was created. Like, you know, this is manufactured or something. So if the person isn't there to manufacture it, could you just go on doing this bad, unwanted behavior? Well, then that's where the behaviorists would say and the proponents would say, well, the person has to want to stop it. If they don't really want to stop drinking alcohol, then it doesn't really matter because, yeah, as soon as I'm not there to put the thing in it, they're going to go back to drinking alcohol. Well, then I don't know why they came to me in the first place. They don't want to stop. You see what I'm saying? So it's kind of like two sides to it. I got a video right there on it. And so like I said, like the US and UR, and then the CS and the CR. So this is kind of like the neutral thing that I put in the middle. Don't worry about that line. It's kind of a weird extra line that I never do. I do top and across, bottom and across, and I just do neutral in the middle. So the drug makes them sick. The drug gets paired with the alcohol. So now the alcohol makes them sick. And then maybe they quit drinking alcohol if it's like a big problem or something. In systematic desensitization, the goal is, so systematic desensitization and aversive conditioning are opposites. Okay, so in systematic desensitization, the goal is to substitute something positive, like being relaxed, as a response for something negative, like being anxious or fearful. Basically, they're getting you to do something. In aversive conditioning, they're getting you to stop doing something. So they're going to substitute something negative, something aversive, for in response for the positive response to alcohol that you liked, or whatever. That's why you were drinking it, right? Like the person with the problem, that's why they were doing it. Situation. So this gets you to stop, to not do something. So if you want to put in there like systematic desensitization, a long word, and aversive conditioning are opposites. If you want to put with systematic desensitization, get you to do something, like go outside your house and don't have this phobia and go out and about, you know, get on an airplane and fly. Aversive conditioning, get you to not do something or to stop doing something, like drinking alcohol or something. Now, new section within behavioral, there's operant conditioning techniques as well. So you remember classical was that, you know, that you saw right here that we did with, you know, Pavlov and the dogs and stuff. Operant was B.F. Skinner with his schedules reinforcement. So there was, remember, there was reinforcement, there was punishment, positive and negative. And you could add it, you could subtract it, good ending, bad ending. And then of just the reinforcement, he had 4 schedules. Remember, fixed ratio, variable ratio, fixed interval, variable interval. So like the amount and the time, is it set or is it changing basically? So if you do those things, that's more of an operant conditioning technique. So voluntary behaviors are strongly influenced by the consequence, right? So, because we talked about reinforcement or punishment, like you have a behavior that's good, your parents reinforce it, you keep doing, you have a behavior that's bad, your parents punish you, hopefully you stop doing it, like that kind of thing. So behavior modification means that the desired behavior is reinforced and that should be withhold for undesired behavior. Wow, what happened there? I'll fix that. I think they withhold the reinforcement for the undesired behavior, like you don't get something good. So under operant conditioning, where did I put that? There it is, operant conditioning. Yeah, a new section of your behavioral notes with that. Techniques. And then put that the desired behavior is reinforced. So the desired behavior is reinforced. And no reinforcement for bad behavior or the undesired behavior. You kind of have a gist of what we're talking about when we look at operant conditioning techniques. All right. Therapists use positive reinforcers in a step-by-step manner. They do it gradually. They reward closer and closer approximations of the desired behavior. Hold on, I gotta open the yogurt. There you go. Enjoy. So they do it in a step-by-step. So they don't give everybody everything at once because then, you know, what's the point? So it's like, you do this, then I'll give you this. All right, let's get a little closer. You do that, I'll give you that. And it like gets the person slowly to where they need to be, if that's a phobia, if that's anxiety, whatever it is. And a lot of times they'll use something called a token economy. So let's write down token economy. Even if you've never heard of the term token economy, I promise you are very familiar with the concept of a token economy. And it probably works for you. Works for most people. Worked for me. So it's an operant conditioning procedure. You hear something, that's Cinderella playing. I don't know if you can hear it or not. It's all that keeps my kids away so I can film. In which people earn a token of some sort for exhibiting a desired behavior and can later exchange their tokens for various privileges or treats. And can later, there it goes, sorry, exchange their tokens for various privileges or treats. So I have a story on the next page I'll tell you about. This was if I wasn't here to explain to you so you could read it. So here's an example of token economy. No, you're not writing this down. So when I was in the 6th grade at Hill Middle School, I was on a team called the Invaders. I just remember this super clearly, that's why. And we had these little envelopes the teachers take to our desk, and they would put Invader bucks in them. And everybody had their own little envelope. And you had to clean your envelope out when you switch classes, because you know you start switching classes. Like I had a teacher for like English and social studies, but then I had a separate teacher for math and science. So like halfway had to switch. And I know sometimes I forgot to clean it out. Whoever sat there the next time got all my Invader bucks. But we would get Invader bucks. We acted right, did right, we're on task, turned in homework, raised our hand and answered questions, just whatever the teacher deemed as good, whatever the teacher wanted. If you did it, you got an Invader buck. If you didn't, you didn't. And so every Friday we would get to go shopping, and they would have like cute little stuff like, I don't know, you're in the 6th grade, like a fun pen or an eraser, like jackpot. Or at least it was back then. And so there would be like, and you could like save your Invader bucks. Like, I want something bigger and I don't have enough for it this time. So I need to act right next week and get more and put both of the weeks together, you know, Invader bucks together and stuff like that. So you could get like school supplies, you could buy homework passes. There's probably some other stuff. I don't remember. I remember getting folders and stuff from them, but anyways, so that made me behave. That made me do whatever the teacher wanted, whether it was sit quiet, whether it was work great in a group, whether it was raise my hand and answer questions, whether it was turn in the assignment, whether it was turn in my homework, whatever the teacher was going for, like I did it because I wanted an Invader bug. And so she was like slowly molding me into like a model student. But did it work for everyone? No. There's certain kids in there, it doesn't matter what you give them, they're not going to do their homework. They're not going to shut up. They're not going to be quiet. They're not going to do their work. Just happens. And they don't really care about your stupid piece of paper because they don't want a stupid folder either. So it doesn't work for everyone, but most people it does. And especially if the reward is something they want. So if a kid didn't care about school supplies or a homework pass, they were just like, whatever, this is dumb. But, you know, if you did, which was me and most people in the 6th grade, you know, that was a really good reward. Right now, would I jump through hoops for an eraser? Probably not. But if they told me, you know, you could do this or something like that, I might be like, all right, let's go. So for most people, a token economy works. You just like give them these tokens over time, and then they just redeem the tokens for whatever they want. Works well in mental institutions, mental hospitals. They're always like giving the patient stuff like you got up, you got dressed, you brushed your teeth, like grooming, you brushed your hair, you made your bed, you did this, you weren't on, you know, you were on time, you cleaned up after yourself. And then they can, you know, exchange them for TV, for privileges, for, you know, stuff like that. Or for stuff, for physical stuff. So usually it works pretty well. And so that would be operant. And again, you can think about those schedules of reinforcement. Like, did they reinforce me every time, every third time? Did I never know what was going to happen? Was it always fixed? Was it a certain amount? Was it a time of day? Did it vary? Was it all those kind of things come into play? All right. And then one of our, we're getting there, last types of therapy, this is technically our second to last type, is cognitive therapy. So cognitive therapy, let's write down that definition. You remember cognitive from Unit 5. You remember cognitive from the beginning of the year. That's your mind, not your brain. Brain is physical. Your brain I can see. I could open that sucker up and look at all your stuff in it. But your mind I can't see. You know, that's the voice inside your head. That's your memories. That's the way you think, the way you process, all those kind of things. So this was all like, you know, the Unit 5 stuff. So cognitive therapy is therapy that teaches, that should not say teachers. I hope I remember to go back and fix all these. Teaches people new, more adaptive ways of thinking based on the assumption that thoughts intervene between events and our emotional reaction. You hear them yelling at each other behind me. The little one's trying to give the older one a yogurt, but I don't think the older one wants it. She's ignoring her. All right, so cognitive psychologists believe that our thinking influences our feelings. The aim is to give people more constructive ways of thinking. So definitely kind of write that down. You know, it's all about more constructive ways of thinking. So more constructed ways of thinking. So the main person here is a guy named Aaron Beck. We didn't really talk about a main psychologist with this approach at the beginning of the year. And he's more of a therapist. So he's a famous cognitive therapist. Aaron Beck. You want to write his name down. And what he did is he did a pretty famous way of treating depression. He reversed the client's negativity about themselves for the situation of the future. Next or two. So we're getting close. She enjoyed her yogurt. Good. Where's that at? He used this therapy to treat depression by reversing the client's negativity about themselves. So he had to reverse the way the person thought. You had to like rewire their thinking, basically, right? So you don't want them to think negatively about themselves, about the situation, about the future, whatever it is. We got to flip that. I got to rewire the way your brain thinks. And so he did this by basically using gentle questioning to reveal that the person was thinking irrationally. Like, you had to show the person that, like, look, your thinking patterns are not making sense. They're irrational, that type of thing. So let me reveal that. And like he said, I got my little quotes down here. Remove the dark glasses through which they viewed life. Like, they were negatively viewing life and stuff like that. Hey, shut that door, Blake. Blake, shut that door. It'll be a little quieter. So, for instance, these are the steps he talks about. So, like, you lost your job. If you had the negative beliefs, you were looking through those negative colored tinted glasses, right? The internal beliefs are like, I'm worthless, it's hopeless, and then that makes the person fall into a psychological disorder like depression, especially if they're more prone to depression. That could be like a trigger for it or something. Or this would be the trigger. Or you could say, I lost my job. It wasn't a good fit. I deserve something better. Something else will come along. And then there's like no depression from it. And so here are kind of ways, cognitive therapy techniques, like you reveal the person's belief, you test their belief, and then you change their belief. So how do you reveal their belief? You question their interpretations, rank their thoughts and emotions. And then, like, those are some examples, right? Like, why do you feel like you got to be liked by everyone? Like, that's faulty. It's unrealistic that everyone's going to like you. Stuff like that. You test their beliefs. Like, you make them explore some difficult situations, like examine their consequences. And it's not going to be a catastrophe if something happens. Let's like de-escalate that down, basically. Work through real worst case scenarios, right? And figure out how we can progress from it, move forward, so we don't have to like sit here and dwell on it. And change their beliefs. Get them to take responsibility, reset their streams, that self-blame and negative thinking, stuff like that. Develop new ways of thinking, a new practice instead of that bad maladaptive habit that they were used to doing. Now the last one, cognitive. Now, a lot of times this goes with cognitive therapy, but this is cognitive behavioral therapy. It's called CBT. And a lot of times people say cognitive and or CBT therapy together. So this aligns more with cognitive than behavioral, even though it's got both words in there, just kind of know that. So last type of therapy, cognitive behavioral therapy. All right, so let's write down what that is. Cognitive. And so that's like a new section in your notes, you know. Behavioral therapy. A popular, integrative therapy that combines cognitive therapy that we just talked about. That's your ways of changing your self-defeating thinking. That's your ways of thinking. You don't want to write the parentheses, you don't have to. Cognitive therapy with behavioral therapy. And remember, behavioral therapy was changing behavior. So if you reset the way they think, and then you kind of apply these like behavioral therapy techniques, you know, like the rewards or something like that, or the consequences punishment, then you will change their behavior because you reset the way they think about it and you rewarded them through their actions. So it's kind of like the both part, the thinking and the actions. You know, we're kind of a two-part thing. We can have thoughts, we can have actions. Sometimes they align, sometimes they don't. Sometimes our behavior changes our thought, sometimes our thought changes our behavior. So it's kind of putting these two together. It's pretty popular, actually. It's one of the more popular ones. If not the most popular one, maybe. It seeks to make people aware of their irrational negative thinking, which is the cognitive part, and to replace it with new ways of thinking, and then to practice more positive behavior. So it's got both components. So yeah, there you go. Now, those are all the therapies that align with the approaches, okay? Next type of therapy I'm telling you about, these are not types, because these are types. These are like ways you can have therapy. But here's the thing. So I'm going to talk about group therapy, right? You can have group humanistic, group behavioral, group cognitive. You see what I'm saying? So it's not like one of these like subsets. We're done with all the subsets. We did psychoanalysis, psychodynamic, humanistic, behavioral, cognitive, cognitive behavioral. How many was that? 6. So those are all your subtypes. Now I'm going to describe ways in which you can have therapy. And the ways in which you can have therapy could align to any of these, depending on what group you join, right? So group and family therapy are up next. So except for traditional psychoanalysis, a lot of therapies actually occur in groups. Psychoanalysis is the one they don't do much anymore, and it was really hard to do in groups because it was that one person. But a lot of times now, even psychodynamic, you can do with more than one person, and cognitive, behavioral, humanistic, all those can be done in groups and stuff. If you want to write down the top, except for psychoanalysis, they're all like this, you can. So new section in your notes about group and family therapy. So group therapy. Therapy conducted with groups. Do you hear the birds, I think it is, or mice in Cinderella right now? Every time I get quiet, it's right at the song time. With groups rather than individuals, permitting therapeutic benefits from group interaction. So it doesn't provide the same level of like one-on-one. Like if I was teaching you one-on-one, that's not the same as if I'm teaching the whole class. If I'm teaching 5 of you guys, it's not the same as if I'm teaching 10 of you guys. I mean, you know, the more people, the less the one-on-one specific interaction goes down. But it's not to say you couldn't get benefits from being in a class. I mean, you're in a class of like how many right now, and you still have, you know, me, and I try to make it individual. So they would do that. They would try and like hit each person and stuff, but just know it's not going to be the same as like you and me sitting here talking. But it does come with some good things, like it saves money, it saves time, you know, and all that kind of stuff. So you'll see some good to it in a minute. So yeah, here are your benefits. Do write some of these down because group therapy is very common, super common actually. So the benefits is that it saves money. It saves time. You know, for the psychiatrist, or psychologist, they could treat more people because I'm treating 10 right now in this hour slot instead of just one, so I can help more people. Now, if I just taught, 3 kids a day because I had 3 periods in one planning, or I could teach, 90 kids a day, 30 kids in each class, like biggest bang for my buck, right? Also going to save money because it's less expensive. You know how it is, like going to a gym class is cheaper than getting a one-on-one personal trainer. One-on-one personal trainer is more expensive because you get that one-on-oneness. Same thing here. Also, it creates kind of a social lab for exploring social behaviors like group interaction, group dynamics, how this is out in the real world, developing social skills, talking about this that's embarrassing or causing you trouble or you don't want to, getting it out, like all this socialness. So you can put like the social dynamics, social skills, however you want to. People see other people with their problems. That's huge. They can see I'm not the only one. And sometimes we feel like we're the only one, and that's a really not good feeling. You feel isolated, again, embarrassed, stuff like that. These girls in the sugar. It's okay. Go. Madeline. Keep getting me off track. See, it's right. Like I'm back in the classroom. Oh, people see other people with their problems. It is very scary to feel like I'm the only one, or I'm a weirdo, or I'm, and you feel like isolated and it's just you and I'm never going to get this fixed. No one's ever going to love me or something like that. And you see, you're not the only one. All these other people feel just like you. And here's what they do. And here's how they make it better. Here's how they make it worse. So you can kind of learn from it. You can also relate. I mean, there's something in like the relating to like someone else is like me and I'm not the only one. And you get feedback, not just from the therapist, but like each other and clients, and you work in a group and, some people can share their experiences and stuff like that with you and try out new ways of behaving, all that kind of stuff. I'm glad you like yogurt. Yeah, I'll get you just yogurt next time. I put them in a room with the door thinking it would make it better than my open living room, but I think this has just made it worse. Because in my open living room, they could have just went in the kitchen and got everything. Live and learn. All right, getting there. Family therapy. So this is a type of group therapy in which it's the family. So family therapy. Hey, can you guys shut that door? So it is a therapy that treats the family as a system. So instead of like 4 individuals, it's one thing, one family, one unit, one system. And it's like your role within that system. Instead of you as a person, you, and everyone's individual, let's make us a whole. And then let's figure out like how to make this whole family work and successful and stuff like that. It views an individual's unwanted behavior. So views an individual's unwanted behaviors as influenced by or directed at other family members. So basically it assumes no person is an island. No one is just a complete individual. Like you're a part of groups, you're a part of friendships, you're a part of your family, right? And your family is probably the biggest group you're a part of. So it views the family as a system as a whole in which the person's action can maybe trigger reactions from other people in the family. And they try and help that person see like when you do this, that's what makes this happen. And then when that happens, this happens. And then the whole family, and they can kind of see their role and how they fit in, how they can help, how maybe they're doing things that are not helping, what we need to avoid, that type thing, and discover basically how to make the family unit successful. There's also other groups or like self-help groups and support groups. The most famous support group, self-help group is AA, Alcoholics Anonymous. You probably heard of AA and their 12-step program. They made a famous 12-step program that a person has to go through, and it starts with like acknowledging there's a problem, and the last step is like helping other people and like, saving them basically too. And many groups, many other self-help groups and stuff like that, support groups have modeled their program after the AA 12-step program. Has been incredibly successful for people battling alcohol addiction. There's an NA for Narcotics Anonymous, and I think there's a bunch of other strands as well for other types of addictions. And so it's been incredibly successful with that. In today's more individualistic age, because nowadays more people live alone or more people feel isolated, even though we're more connected with social media and stuff, it's like we feel more isolated and alone. There's been an increase in popularity for these groups. So if you want to put about support groups, self-help groups, those are also types of groups in group therapy. You can put AA, Alcoholics Anonymous, and 12-step program, and how those are more like prevalent today. All right, so the next part, this was the next module. This was the second of the 3 therapy modules. And since it has to do with psychotherapies, I'm going to do it. It's not too long. So prior to 1950, psychiatrists, who are the doctor part, those are the MD, the ones that prescribe medicine and do the medical treatment. Remember that from the beginning of the year, difference between a psychologist, psychologist, counselor, psychiatrist, doctor. Prior to 1950, it was pretty much doctors who were treating everyone. There was no such thing as like counseling and working with people in psychotherapies and stuff. But then that kind of took off. Today, providers can include people like clinical psychologists. Those are, clinicals like in the hospital medical world. They're not a doctor, but they're in the medical world. Counselors, from school counselor to, all kinds of job counselors, psychologists, counseling psychologists, social workers, clergy, people in church. There's religious counselors, stuff like that. Marital counselors. That's probably one of the most commonly seen things, types of therapy and stuff. People go to marriage. They see marriage counselors go to marriage therapy and stuff like that. School counselors, psychiatric nurses, which are more on the medical doctor, and more. There's a ton of different types. They help industries, like there's industrial ones. They help businesses, the military, schools, forensic, crimes, police, you name it. So I like this quote that was in your book. It was from a famous therapist, Albert Ellis, with the cognitive approach. And he says, the trouble with most therapy is that it helps you feel better, but you don't get better. You have to back it up to get better. Action, action, action. So it's kind of cool. Like you can think it all you want, but you got to do the legwork. Like you got to put the effort in, and you got to, actually work at it and stuff like that if you want to improve your well-being. So is it effective? If you ask clients, about 90% reported feeling better. And if you ask the clinicians, the psychiatrists, the therapists, psychologists, stuff like that, about 80% of them believe that they help someone. And then some people are like, well, are those numbers accurate? Like, can data be misleading? What if 90% of y'all would have gotten better on your own, even if you never went to these sessions? What if 80% of the, psychologists that think they help someone, what if they never know because the person just quit coming and said, I'm fine, but inside the person's like, this is not helping me, or I don't like this therapist, or something like that. Like, do you ever really know? Maybe they're thinking that they had these success stories, but they really didn't. And so your book talks more about that in depth. There's this guy right here, Hans Eysenck. He is a famous psychologist, and we will talk about him more in later units. And he reported that about 2/3 of patients improved that went to therapy. But he also found when he did similar, like, then not, improved or not. Like, so he took only people that went to therapy. And it was basically, yes, you improved, no, you didn't. Well, 2/3 of those, yes, they did. So he's like, sweet, therapy is very effective. Then he took just a group of people who did not go to therapy. And it was like, yes, you improved, no, you did not. And literally got like almost the same results. Not quite 2/3, but almost. So even if you don't seek treatment, like you can improve over time and stuff like that, or you can improve yourself and things. So we use this thing called a meta-analysis. I think we talked about this in Unit 1 with research methods. This is where you use a bunch of different studies just to get like an overall baseline data, just to get like a big grouping, kind of understanding. So let's write down, so this part of your notes is just kind of about psychotherapy, if you want to make it that, because you're not really in family group anymore. So if you want to make like the last section like about psychotherapy, not a ton you're going to write down here. So meta-analysis, though, let's write that down. A procedure for statistically combining the results of many different research studies. So lots of research studies like this one of Hans, we look at to get like an overall, is it effective? And there's your meta-analysis picture at the bottom. So the control group would be people who did not receive treatment, and you can see it can be pretty effective. The blue line is people that did receive treatment, and you see it's just slightly more effective. So about 80% of people that receive treatment are better. About 50% of people who do not receive treatment are better. So even if you don't receive treatment, there's still hope. You know what I'm saying? That type of thing. Also, psychotherapy is cost effective. So, like, you pay for therapy, right? But when people spend their money on therapy, they spent less money on medical things, like medical treatment. It dropped by 16%. But also think about it for the long run. Like, if you're getting help, maybe you're not going to fall into a life of crime, a life of drugs. Maybe you're not, it's going to prevent accidents or being out of work because you're suffering from depression or anxiety or whatever, and you're not going to work. So you're not being productive. You're not being efficient. And again, like medical costs, avoiding hospitalizations and stuff like that. And just overall, you're a more efficient person. Like, you're getting stuff done. You're going to work. You're having relationships. You're parenting your spouse, your parents, your friends. You're involved in this, groups, this. And you're just like a more productive member of society. So like overall, paying this little amount for therapy can increase like the folds, like just increase tenfold, and like what it provides. So which type of psychotherapy? Well, statistics have failed to pinpoint a best one. You can't say which one's best. It's like I told you in the earlier video, it's your way you look at stuff, and it's the way your therapist looks at stuff, and like you two have to like mesh and get along and like each other. And so there's all these things that come in, but I can't say definitive like behavioral or cognitive. Although they have done studies to see what's better for certain things that you'll see in a minute. So clients seem equally satisfied if treated by a psychiatrist, a psychologist, or a social worker. If they were treated individually or in a group, they all, basically had the same outcomes. There's little connection. This should make like therapists and psychologists feel good, because even if you're not the best, the top of your class with all these accolades and all these years of experience, it doesn't really have a connection. Like, if you're a genuine person, you connect with the person, like they can be healed. You know what I'm saying? There's not a big connection between their experience, their training, their supervision, their licensing, and the client's outcomes. If the person's real and does a good job, then it's going to be good. So which type of psychotherapy? So let's look at things that are a little more common. So psychodynamic therapy best helps people with depression and anxiety. That's kind of what it's known for. Humanistic helps people with mild to moderate depression really well. Behavioral helps people with phobias and compulsions. We talked about phobias when we were writing this down in our notes. And cognitive, or CBT, best helps people with anxiety, PTSD, depression, stuff like that. Therapy works best when the problem is clear. That's definitely for sure. If you can't get to the root of the problem, there's more time, there's more work, there's more effort, energy, and how do you know if your solutions are really going to help? That type of thing. So if you know the problem and it's clear cut, you're going to be way more successful. Evidence-based practice. So does it help, and how does it help? So these are two things we're going to write down. So evidence-based practice is kind of like it sounds. So evidence-based practice is a clinical decision making. So clinical decision making that integrates the best. Can you hear them? And they're yelling at each other. Miss you guys, really do. That integrates the best available research with clinical expertise and patient characteristics and preferences. So it's everything I just said. Like, what is the therapist really good at? Like, what's their expertise? But like, what are you expecting? And what type of person are you? And what's the problem we're fixing? And what type of problem is it? And you put all that together to make a decision of how you want to be treated. Like, I do, you do. We look at the problem. Like, maybe I'm not right for you as a therapist. Like, maybe this type of therapy isn't right for your problem or something. And that can happen. And so you kind of like put it all together to figure it out. Then you got a therapeutic alliance. Did I spell that right? Yeah, I think I did. Therapeutic alliance. So I don't know if I need that E in therapeutic. I don't think I spelled that right. I'll have to go back and check. Therapeutic alliance A bond of trust. I hear that door. Hey guys, shut the door, please. They listen about as well as you guys do. I'm just kidding. So, a bond of trust and mutual understanding between a therapist and client who work together constructively to overcome the client's problem. So this is the bond, this is the relationship you have. And if you don't have a relationship, like, you're not going to get helped. You know what I'm saying? Like, if you don't trust the person helping you, you're not going to do what they say. You're not going to want to do what they say. So you got to like the person. You got to trust them. You know what I'm saying? You have to have that connection. And it's just like anything with life. Sometimes you really connect with a teacher, sometimes you really don't. And I bet when you connect with a teacher, you learn better, you like it better, you enjoy going to the class, you do better on the work, on the test, you just know it better in your head. And it's not to say that, like, the teacher you don't connect with is doing a bad job, because that might not be the case at all. But if you just don't connect, then maybe you just don't care about the material. Maybe you don't do as well. Maybe you don't know it as well in your head. Well, it's kind of the same thing here. It doesn't mean the therapist is doing a bad job if you don't get the warm and fuzzies and get this, like, amazing connection. But if we're going to be honest, you're going to do better if you do have an amazing connection. And so, you know, it's definitely something people do. They try out different people, different therapists, and when you get that connection, they stick with the person. And the therapist has to work at that too. Like, they're not going to be a good therapist if they're not making connections with their clients, you know, and their clients aren't going to get helped as well. So it's this kind of like give and take that both sides have to, like, come together to do. But when they have it, you can work constructively. So constructive is like constructive criticism. You know, if you construct something, you build it. You're trying to build a better you. You're trying to fix stuff about you. And so sometimes they're going to tell you things that aren't nice or aren't what you want to hear. And sometimes it's a tough pill to swallow. Like, sometimes it's tough love. People have to tell you things you don't want to hear, but, like, let's be real, that's the truth. And that's what needs to happen. And you needed to hear it, even if you didn't like it. And so if you have a relationship, you can take that stuff when they're telling you that and really apply it to your life more than, like, oh, I don't like you, or you don't like me, or I'm not going to do that, or shutting down or something like that. And that's what would actually help the person, like, overcome their problem in the end. So how does it help? You know, people are demoralized, right? Like, they feel bad about themselves, or they're embarrassed, or they don't want it. Like, nobody wants to be like this. And most people with psychological disorders do know that they have it. And they know it's not normal, and they don't want to be like that. They just can't fix it, right? So they think they feel bad, and they think that therapy will make them feel better. It helps by letting the person get a new perspective. Like, they're going to explain things to you that you've never thought of. Like, I've never thought of it in that way. Or, like, oh, that totally makes sense. Or, like, I never even considered that. Like, wow, yep, you're right. So there's, like, explanations for the symptoms, and there's alternate ways of looking at it, looking at themselves, and then how you're going to respond to the world. Like, instead of that, why don't you do this when that happens? And the person's like, yeah, I do see how that would be better. Wow. You know, that kind of stuff. And they're empathetic, like, they're trusting. You have that caring relationship. And maybe someone with a psychological disorder doesn't have a lot of caring relationships in their life. You know, maybe their psychological disorders push them away from other people, or made it so that they can't develop these. So if they get one of those with their therapist, that's a really good component of their life. And they can evaluate themselves. They can gain their own insight and stuff like that. And I think this is the last one. Woo-woo. Culture and values. So this is pretty interesting. You should read about it in your book. Your book talks extensively about it. You know, therapy is different in different cultures. Therapy is different here in America than it is in France, than it is in China. Okay. And, you know, our life is different than the people's life in Japan. And so, like, a therapist is going to be different than a therapist in Australia and Mexico and all kinds of places. And so, like, you know, an American therapist is going to basically try and help you so that you can fit into American life and culture. So if a therapist or a client are from two different cultures, like, think about someone from an Asian culture that's very, like, collectivist, and they're about the whole and the group and the family. And they meet an American therapist that's very individualistic, like, fix yourself, help yourself, do this for yourself. They're not really getting each other, because this person's like, but I don't work that way. I'm not individualistic. And this one's like, well, I don't work that way. Like, I am individualistic. So a lot of times, if a therapist and a client are from two different cultures, like, it might not work. And so your book talks about the APA, the American Psychological Association, doing all this, like, sensitivity training and culture training and stuff like that. But You know, maybe that explains why minorities in America are very reluctant to use mental health services. It's not very common that minorities, especially immigrants or people here from another country recently, they either don't use it or they stop using it before they're fixed or healed or something like that. And perhaps that's a reason why, who knows? Yeah, that's it. Woo woo. All right, so there will be another section coming with biomedical. I will get that part of the PowerPoint up and then I will get you a video as soon as I can. Enjoy. Bye.